Hi, I'm really happy to introduce the next speaker, which is Marilyn Bartlett. You are in for a treat. Marilyn, she got on the map for her outstanding work in Montana that she's going to detail. And I have to say, my favorite quote of the last several years was in response to that work. And it was written up in ProPublica, then went out to NPR and a bunch of others. And this is the quote. It's talking about her work and how transformative it was for the state of Montana. She wasn't afraid of ruining her career or making people angry, says Scott McClave, a consultant with Alliant Insurance Services. Bartlett says it helped that she was near the end of her career and didn't need to please people. Quote, "I'm 67, so I could give a beep." She says, "What are they going to do? Fire me? I'm packing a Medicare card." And that kind of tenacity and fearsome desire to change things really captures why Marilyn's a vital part of the Health Rosetta community and has really been selfless in sharing her story. Early in her career, she was the controller for a Blue Cross, state Blue Cross, and then a CFO for a TPA before her role that she'll share with the state of Montana. And it was for this work, though, with Montana that she was named as one of Fortune's 50 World's Great Leaders in 2019, along with people like Bill Gates. And she was also inducted last year into the Montana Business Hall of Fame. She's gone on to do great work with RAND and others, along with her role as Senior Fellow at the National Academy for State Health Policy, and has other states and public entities following her lead. In fact, she gave me a little sneak preview about a great report coming out and great set of data and tools next week, which I'm really looking forward to. And I'll say, my favorite part of the country are the mountains of central Idaho that Julie Gunther was talking a little bit about yesterday, but my favorite people are Montanans. Lynn Ann, who's the maestro behind the scenes of the Hint Summit, and Marilyn are perfect examples. They're delightful people, but really tenacious fighters for a better world. So with that, I'm pleased to introduce my friend and a source of a lot of inspiration, Marilyn Bartlett. So Marilyn, hop on stage and look forward to taking everybody through your story.
Dave, thank you so much. What a wonderful introduction. I very much appreciate your comments and appreciate the Health Rosetta working relationship. Well, thank you, Hint, for having me today. I'm excited to be here. I thoroughly enjoyed the sessions. I'm learning so much about DPC, about the vendors in this space, about the support. And every one of you, I am so impressed with. You are embarking on a whole new world. And it's really, really impressive. So I thank you, and I'm anxious to share my story a little bit with you here. So I hope you can see this screen, and I will start presenting my slide deck. I am a CPA, so you'll see accountant D's written all over me, but I don't think I ever thought of myself as a leader. I was doing what I thought was the right thing, which I think many of you are doing and probably not realizing the significant leadership role that you're playing. So my story starts out when I was ready to leave the TPA. I was 64 years old and ready to retire. And I was recruited to the state of Montana Employee Health Plan. And the Employee Health Plan was going through a tough time. This is the slide deck. I came to the plan in late 2014, and this projection, the red line, showed what the actuary presented to the Montana State Legislature in January of 2015. The plan had just lost $28 million, and it was targeting to be minus $9 million by December 2017 if something didn't take place significantly. Well, the initiatives that we put in place were successful. We were able to at least flatten the curve while we got some initiatives designed and in place by the end of December 2015. By the end of 2017, the plan had 112 million in reserves, way beyond the projections. And in fact, we had more money at that point than the state of Montana General Fund. So the legislature met in late 2017 and passed a bill to be able to recover 25 million from the state health plan to help out the state budget. But what did we do? We contracted with all Montana hospitals that they would be paid as a multiple of Medicare. We contracted so there'd be no balance billing. It was a very intensive data-driven process where we knew what they needed to break even and we knew what we were paying, and we successfully put that in by July of 2016. We implemented a transparent pass-through pharmacy. And what I'll be speaking mostly about today are the primary care Montana health clinics that we had. They were on-site, near-site health clinics run by a vendor. We paid a PEPM fee, and I'll tell you more about those. We terminated contracts. We contracted with a new TPA. I couldn't get my data from one of the large national carriers. I couldn't see, everything was so secret, so I fired them. And in January 2016, we brought in a smaller TPA. I got rid of the PBM because there was spread pricing and rebates retained. We went to a transparent pass-through, saved 7.6 million the first year. And I terminated the consultant, which was a large national consulting firm, but I was not getting the work I needed. So we hired a consultant very much following the Health Rosetta model, and we're successful from there. Now I throw these next ones in because this next one, a cloud-based enrollment and data warehouse system, you might think that was simple, but I didn't realize what it was going to happen when I challenged the internal state government. The cloud-based enrollment system took me 39 months from start to finish to be able to roll off of the large state ERP system that required 116 manual entries every payroll period, that required over 500 audits every payroll period. I wanted a cloud-based enrollment system. I wanted to be able to get to the data. What I didn't calculate very well is that the administrator of that system was married to the governor's senior policy advisor. So I was in for a challenge there, but we got it done. The second was a data warehouse system. I no longer wanted that plan to be dependent on a TPA, a large carrier, or their consultant for their data. They needed to own their data, and they needed to use it to make wise decisions. What I didn't see coming was that the state IT department and the Medicaid department felt they could build one. I really didn't have faith in it, so I had them sign a memorandum of understanding that I would pay $254,000, and they felt it could be done in 6 months. But 18 months later and 1.7 million, I was finally able to prove that it was a failure, and we were able to go out for a cloud-based data warehouse system. I right-sized the staff. We cut staffing significantly. I no longer needed a lot of data entry and auditing people. What I needed were people to analyze data and really go the right direction with the plan. Now I want to focus on the health centers. What the legislature did was pass Montana Senate Bill 418 in early 2015. And it has written all over it what all the middlemen and the hospitals and the insurance companies, everything that they wanted the state to do. So I won't bore you with it, but some highlights is they passed this bill that a condition of a 2017 pay increase for state employees was contingent upon us turning this health plan around. And we needed to consider cost containment efforts. We need to focus on primary care management and coordinated care. And this was right in line with Blue Cross Blue Shield's PCMA initiative. We needed pilot programs to improve health outcomes. This was fitting right in with the hospital system trying to build an ACO. We needed control review of referrals. And we needed the state health clinics to require co-payments. So I jettisoned over all of those recommendations, and I knew I was going to put more money into the health centers and we were going to provide more services. So as you can imagine, I faced some of the things that you're facing right now. I was disrupting the status quo. So here I am at the end of the legislature in April 2015, and I've got to turn this plan around. Well, the first thing that happens is two large hospital systems decided to come together and form the Rocky Mountain Accountable Health Network. It didn't exist. They wanted to build it on the backs of the state employees and the state pay for it. They immediately went to the governor's office and legislators and started their very heavily lobbying to go that direction. Right on the tails of that was the largest insurance carrier in Montana, moving forward with their patient-centered medical home system and really going to legislators, going to everyone imaginable. That's what we needed to do and close our health centers. By June of 2016, the Montana Hospital Association was on the same path. They met to plan their 2017 legislative agenda, and number one on the list was deal with the Montana health centers. The hospitals were taking away hospital privileges of the doctors in the health centers. They were becoming quite argumentative over the whole process. Then by November 2016, this came internally from the governor's office, and DPHHS was a big move for Montana's CPC Plus initiative. And there was a push to terminate the health centers and coordinate with the hospitals on pilot projects for CPC Plus, but I wouldn't do it. By June 2017, the legislative push to end the health centers had gone, I thought, to the ultimate. They went to legislative audit, and legislative audit did a performance audit where they recommended the Department of Administration work with stakeholders to determine if the Montana health centers should continue to be an option for state employees. And those stakeholders they recommended were hospitals. Well, fortunately, I had a very astute director and a very astute budget director, and we worked with stakeholders. We worked with the unions. We worked with the people using the health centers, and we were able to stave off that. So meanwhile, while all that was going on, I said, we're going to refocus our Montana health centers on primary care. It had become almost more urgent care. So we decided we're going to listen to you. Instead of trying to tell you what we think we need, which had been happening, you tell us how to get this focused on primary care. We really reinitiated the no copay 20-minute appointments. We implemented contracts for radiology and lab services that were priced at 125% of Medicare with independent radiology, independent labs. I then extended that offer to any state employee health plan that went to any doctor. If they wanted these services with no copay, no coinsurance to them, they could come to the Montana Health Center, meet with one of the staff there, and process their order through there. Now that kind of really disrupted the hospitals. And I enjoyed one of the presentations this morning because it rang a bell with me. You do not need duplicate radiology, duplicate lab services. The Montana Health Center really put a cap on that. We increased staffing. We added health coaches. We added other public employer plans could join on. Now, by the time I left, we were at a point that we had 60% savings over network primary care, and we were able to prove it. So the lobbyists, the disruptors, the middlemen started backing off a bit. When working with health centers, I pulled together the Montana Independent Pharmacists, the University of Montana Pharmacy School, 70, and definitely the Montana Health Centers. Those three came together and helped us develop a medication therapy management program that included a diabetic care club and an asthma care club, that they could all work together, and it's been very, very successful. As it stood when I left and still is now, 73% of the state employees have immediate access by geography. The health centers are very, very much an overwhelming benefit to the state, and I argue that they're a big contributor to our cost savings. So I started thinking about your world, and I started thinking about all the middlemen and the invested interests and all the obstacles that I faced, and you guys face them all. I drew this little chart because it was how I see the world. Being an accountant, I have to do these flow charts, so pardon me, but the green lines show how the money flows from the patient. Look at all of this. It's a spaghetti chart. The red shows the flow of the actual care. And going to the primary care doctor, who can maybe only see the patient for a few minutes before referring them to specialists and on for additional testing, of course it's going to leave the patient and the doctor very confused. And I'd be remiss if I didn't bring in the insurance companies, bringing in their own disease management, their own prior auth, their own case management, their own data and analytics, that many patients have to go through their insurer before they can even make an appointment if it's a chronic condition. And then this is my view of your world. My view of your world is that the patient's happy and the doctor's happy. There's one-way flow of that money. It's very transparent. I apologize for calling it a doctor's office, but I couldn't find an icon yet that says DPC clinic, but I know they'll be out there. You can get the appointment quickly. You can go directly and see the doctor. The doctor that you see handles those directives to radiology, to labs, to pharmacy. Maybe some of those are located within the DPC clinic. And it makes it really, really great for the patient. So of course, the patient and the doctor are going to be really happy. And this is what I saw with our on-site health clinics. This is the way that we were able to save a lot of money and really increase access and increase the health of our members. So I applaud you every step of the way you're going, because you're up against some big, formidable objections, but you're doing great. And finally, I wish I had some words of wisdom. It's tough. It was hard standing up to the obstacles. And I wish I knew some secret message to give you. But in closing, I think you aren't alone. And I've seen that in attending your sessions yesterday and today. You aren't alone. The support you have from HINT, the support from the numerous vendors, I've thoroughly enjoyed learning your world. You aren't alone. You've got each other's back. You're going to be okay. And you're in this to do the right thing, just as I was, and don't ever forget that. I'm sure you don't. But when things get really tough, really know it's not easy to do the right thing when you have a lot of players out there that stand to lose a lot of money. And don't forget to celebrate your successes. Be really proud of yourself. You're going to have some tough times, and celebrate your small successes as you go along, because you really deserve it. And I put this quote on my, I'm going to show my age here, okay? I've been enjoying all the great little quotes that have been coming through on the presentations, but, I'm going back to Ronald Reagan here. But I really liked this quote. Status quo, is Latin for the mess we're in. It's the right thing to do to shake it up. And I'm really proud of each and every one of you, and proud to be a part of this. And I think we'll open it up for questions now.
Thanks so much, Marilyn. I love that quote. I've never thought of it that way, but I think it's just so apt. So we've got a bunch of questions, but first of all, I just wanted to thank you for being here, sharing your story with the direct primary care community and our broader community here at HINT. So thanks so much. It truly is an inspiration. So the first question we had for you here is, what do you alluded it to a little bit, but what do you think of DPC? And if you were to do it all again, how would you consider working within the how would you consider or not consider working within the DPC community?
I definitely, I totally really support DPC, and I support it totally in Montana. And when I left the state, I wanted the health plan. I went to work for the Commissioner of Securities and Insurance, who is a strong supporter of DPC and was getting a lot of push about DPC being insurance. So he issued an authoritative letter saying it's not. We would have gone with DPC. I don't think the state should be in any way in the position of delivering the benefits. We should be providing the providers that deliver the benefits. When we started this in 2014, there weren't DPC clinics, but now there are. And I think we would have gone that direction. There would have been more locations throughout Montana. We wouldn't have been limited to just 5 locations. We would have been limited to places that wouldn't have, and we could have easily contracted with the DPC network.
So you've created a blueprint for other state governments to follow, and really just to sort of, the question I guess is just how can other states replicate this type of success? And do you have any tips or just thoughts about kind of actionable things that can happen in that respect?
You know, I'm going to be looking to you guys to help me. I went to work for NASHB, and my job there is to work with state employee health plan administrators to help them move the dial forward. And I've written pieces, I've written a blueprint of exactly what I did. And I mean, we did this in really 18 months. You can do this. But I meet with the state employee health plan administrators, and there's probably only a handful that are willing to go through the disruption and the push. But now it's interesting. I'm having state legislators reach out to me, state lieutenant governor and governor's offices, looking at possible legislation to force these things to go through. And I think that people have to remember their fiduciary role. You are responsible for that plan and every penny spent. And I continue to encourage the state employee health plan administrators. I'm finding movement on the employers, the employer business coalitions that are around to start moving forward. So I have faith it's going to move, but it's a lot slower than I have patience for.
Yeah, often disruptive innovation, it can take time to catch. But so one question that came through was, what has the state employee response been like? Did you get, I guess, the feedback at that level?
You know, state employees don't really realize anything changed, except they got pay raises. In 2017 and in 2019, they got nice pay raises because the health plan needed no more money. And even going out with that, the health plan ended 2019 with $54 million in excess reserves. So the employees, it was interesting. We kept employees communicated. They were just worried about losing their health centers. And I thought, ooh, I'm going to pivot on that one. So I worked with the union leadership and the employees to help me with that objection I was getting. And they loved the health centers. They loved that. And then I pulled them in to help me with the hospitals that weren't willing to negotiate to do mailing campaigns. So employees probably don't know much happened. They still have their benefits, no changes, in fact, enhanced benefits. They don't pay anything more, and they got pay raises.
So did you or have you consulted with people in other states who are trying to change the system?
Yes, I have. I've worked a lot in Colorado. They have a purchasing coalition going on there, and they are making headway. And they're looking very heavily at DPC, and that's great. Because if the hospitals won't move, fine. Just start looking at other options. Start working with DPC. Start looking at using your standalone surgery centers. There are a lot that a DPC can do for outpatient, because really, that's where hospitals are making their money now. Move that stuff back into these other centers where it belongs. I'm working a lot with Indiana. Within the state employee health plan group, you'll see some great movement going on in New Jersey. Georgia's starting to work. I've been working with their office. Texas, working with them, working with Rice University quite a bit on this model I built to tell how much hospital profits are being made on Medicare, Medicaid, and what their break-even points are. Rice University is connecting it to HCRIS, so everyone will have access to it. So I think people are coming along slowly. I'm not real skilled at meeting people where they're at and so I'm relying on others to help me with that, like Dave Chase's group.
Right. Yeah.
But I think state employee health plans don't have a choice. This is a year of terrible budget crisis, and I've written some documents how they can step up and do immediate savings and be heroes to their state budgets and their members.
So then why do you think so many states are resisting common sense approaches like what you put together, or just in general?
I think it's disruption. I think it's easier to stick with the status quo. I'm finding that a lot of the state employee health plans rely on their large brokerage firms, their large carriers, to house their data, tell them what products. I find them stacking products, kind of buying whatever comes down the road. I find a lack of really digging in and making those changes. Now, I don't want to stereotype. There are some buckets out there that are doing some really good things of starting to crack the nail. But one thing that hits hard is when you start dealing with state employee health plan, you have opened the door to every insurance lobbyist, every hospital lobbyist, every medical association, the federally qualified health centers. You have opened the door for all these middlemen to come right in. And then you're dealing with legislature, executive branch that all have these ties, and it's tough. So I'm coaching them to find your champions and just chart your course and stick with it. And I'm really thinking that the leverage might come now with the financial state.
Hey, so what I think you mentioned in there, you integrated health coaches. What inspired you to do that, and how was that received, and what was some of the results from that?
Oh, it's been really great, and that was not my idea, which is lucky. Fortunately, I'm not a clinician like all of you are out there, and I know I'm not. So I rely on the clinicians to give me that advice. So I worked with the health center vendor and their medical director, and I said, what do we need to do? And they recommended health coaches so that we could help people with behavioral health, exercise, different facets of health, and they would do classes, they would do sessions, they do intervention. I made sure that they got the data at the health center from our health, because we had the data warehouse. They should have the data to know what other things that people are seeing. So that was the idea of the vendor that ran the health centers, the medical people, and people loved it. Patients loved it. They could be identified as someone that needs help. They'd go to their individual coaching sessions, and it's been really successful.
Awesome. And then just the last question for you, Marilyn, before we have to drop. Where can we find your blueprints or just any resources to help other states with similar initiatives? Or any tips for us there?
Well, now that's a really good question. I'm providing Dave Chase some links. I wrote a very simple document. I did all this analysis in Excel and Access because I couldn't get my data. But I have a very simple document that shows kind of step-by-step what we did. And I will provide those links to whoever wants them.
Fantastic. Thank you so much, Marilyn. Awesome talk.
Thank you.
Total legend. And we're really excited to have you sort of becoming part of this community. So thanks so much.